Okay, good morning, everybody. The hour is getting late. I hope you guys had a great Saturday night in Orlando. I think most of us mainly spent it in the hotel with the Marines, but I guess we should just get on with it, huh? Let me just get a sense. How many people have burning questions that they want answered? Raise your hand. Okay, I just want to get an idea of like time in terms of how much time to allot for things. Okay, so without further ado, it is my wait. There's some further ado. It's in Rochester, New York. He's the former editor-in-chief of Neurology, the official journal of the American Academy of Neurology, and past president of the American Academy of Neurology. So do they call you Mr. President for the rest of your life now? Dr. Griggs has spent a good deal of his career caring for patients with periodic paralysis, being credited with the discovery of acetazolamide for the use in periodic paralysis. He directs the largest clinical trial of periodic paralysis to date and is responsible for bringing together the best minds of periodic paralysis, physician researchers, in advancing this area of medicine. So we are so lucky to have this most heavy hitter in neurology in our corner. Thank you, Dr. Griggs.
So thank you very much. I appreciate the opportunity to meet with you. I know many of you, and I hope I'll get a chance to say to all of you who I've met before, be sure to say hello. I'm going to be trying to stay around for all of the morning and into the early afternoon. So it's a pleasure to be here. I think this organization is terrific. Jake Levitt has done just an extraordinary job, and he is always enthusiastic, and actually has been a big help in our research, and having a patient who understands and a physician who is a patient and is willing to devote enormous energy to this disease and to the patients with the disease is really truly a remarkable thing, and it's a great honor actually to be associated with Jake, so that I'm pleased to be here. I have many years of experience with periodic paralysis. I don't have all the answers, despite the fact that it's been my focus, my career for my entire life, there are many areas of the disease now that are getting so subspecialized that I think no one person can even understand this one disease, which is remarkable. This is an area of subspecialization in medicine, where you think you know everything about everything when you start, and then realize as the years go by, you know less and less about more and more. So my focus, my career focus, has been on developing treatments for periodic paralysis. And so that's what I'm going to be talking most about today. And I'm going to try to stick within my 45 minutes and also be certain to leave time for questions. But some people may not have time to ask their questions or not want to ask their questions. Here I'll be happy to see you for individual discussion if you catch me in the break at other times. Now the other thing that I've been particularly interested in is bringing together, as Jake Levitt said, bringing together a large group of investigators from around the world who are interested in periodic paralysis. And so many of the people who've spoken here at your meetings in the past, and many of you are familiar with, are part of a big collaborative group that has brought together the experts from England. That's Michael Hanna, but he in turn has trained many young people. Bertrand Fontaine from Paris, Giovanni Mela and Valerie Sansoni from Italy, Louis Tachik from San Francisco, Steve Cannon from Dallas, and we have centers that are working with us at the Mayo Clinic and University of Kansas, in the Brigham at Harvard, in Boston, in New York City, Philadelphia, and in many other areas of the country. We have brought together specialists interested in periodic paralysis, working with us to develop better treatment for these diseases. We're particularly interested in Anderson-Tawil syndrome because Tawil was one of my trainees in Rochester. He's now a professor there, and that first really characterized this disease and has now begun to develop approaches to thinking about treating this very complicated, very, very rare disease. And so we've actually have a clinical trial we're working on in that. The other thing I've been particularly interested in is training young people. I'm pleased that Jake has brought 2 medical students who, what did he say we were going to do to them if they didn't go into neurology? But they're going to be speaking later this morning. But I've been very interested. I now have a young person from China, from mainland China, who's been training with us for the past 2.5 years. He's going to be going back there to set up the Center for Periodic Paralysis in China. If you think about it, if you're interested in finding treatments for this very rare diseases, it's a real opportunity to have 1.1 billion people, because you can see there'll be literally thousands of patients so far undiagnosed and largely untreated in China. So Dr. Ching Kerr has trained with us for the past 2.5 years. He's going back to establish a center. We also have 3 other fellows who are training in Rochester in channelopathy research. So with that, let me turn to my topic. I was given the topic of hyperkademic periodic paralysis, but I think I'm going to talk more broadly about various issues, and I'm going to try to update you on some of the things we've been doing. So I don't have a way to advance it. I'll just, next please. So just, there's going to be more detailed discussion, so I'm going to quickly go through this, because this is an earlier onset disease. Often the diagnosis can be made within the first year of life because of the myotonia that many of the patients have. I suspect there are a few of you who have never even, there's quite a few who probably have myotonia, but there are also quite a few who don't even know what it is. And so I'm going to show you a couple slides of it. There is overlap with myotonia, paramyotonia congenita, that's not congestion. Sorry for that. They tend to have brief attacks, though persistent attacks are frequent. I'm going to make this point over and over and over again because people are unaware, and I'm certain that most people, including patients and experts in periodic paralysis, are unaware of the fact that when somebody has an attack of periodic paralysis, I think it leaves residual weakness, and that weakness, often missed by experts, usually missed by the patient themselves, until it becomes cumulative and severe, I think is very important. So I say brief attacks, that's what patients recognize, but I think in fact attacks may last, in a sense, forever unless you do something about it. But I don't think the strength recovers. And that's what I say about the inter-attack weakness. Next, please.
Well, first, can you explain just myotonia for, I think, some
I'm going to show you.
Oh,
okay. Now, this is a patient with myotonia, very muscly, strong man who flexes like this, and then next slide, when he relaxes, he can't. Okay, there's actually a group of goats. You can go on the web and see these goats that they get startled and they start to run and they fall over because they're so stiff. This is very disabling, and patients with hyperkademic periodic paralysis can have very severe myotonia. Next. This is one of my fellows from many, many years ago. Actually, it helps if you want to be my fellow to have one of these diseases. So I don't know about our medical students here. I don't know if they're really authentic or not, but we'll see. So this is my fellow who now is a professor of neurology looking up. Next slide. He looks down and you see that the eyelids stay stuck up. That is eyelid myotonia. And this is a minor symptom, though I would say if he does this and he's given a lecture or something like that, it looks kind of weird. So the next, now this is a little girl with hyperkademic periodic paralysis. If she closes her eyes, yeah, thank you. Just yelp if my arm weakens. So this is a little girl with hyperkademic periodic paralysis. When she sneezes or closes her eyes, next slide, she looks like this after she does that. And this will stay, this eyelid myotonia, or orbicularis is the muscle involved, this will persist for 1, 2, 3, 10, 15, 20 minutes, and if it's cold, it may last for 30 minutes or 45 minutes. So this is disfiguring this symptom. So people often have an abnormal look to their face, so that myotonia is quite troublesome. Then next, so this is going to show you the grandson at the top, grandmother at the bottom, and the two sisters looking up, and you see the eyelids. Okay? And now I'm going to show you the most remarkable thing. You can see the eyelid myotonia. They're going to close their eyes once hard. They open it. Twice. 3 times. 4 times. And 5 times. And you can see their eyelids are scrunched shut, and they have this, what we call myotonia paradoxical, or paradoxical myotonia. This is critically important. And I'm going to tell you something. If you remember this, it will put you ahead of all neurologists except experts in periodic paralysis, and even a few experts in periodic paralysis haven't figured this one out. That sign, paradoxical myotonia, is virtually pathognomonic for sodium channel myotonia, hyperkalemic, hypokalemic periodic paralysis. So it's a bedside thing that you can diagnose this. Now you need to do it if you're a doctor. I'm not giving you the lecture I give specialists in periodic paralysis. You need to do it in normals a few times, because even normal subjects get a little bit of sort of sometimes quivering of the eyelids. But this is where they cannot open their eyes, like that little girl, with repeated activity, is essentially, as far as I've seen, we always find a mutation in the sodium channel when we see that. Okay, so now, the last couple of points on hyperkalemic periodic paralysis. It's a bad name, hyperkalemic periodic paralysis. I spent about 20 years of my career trying to get rid of the name, because it's a misnomer. 50% of the time, people who have an attack of periodic paralysis in this disorder are not hyperkalemic, and 10% of the time they're hypokalemic. So that this is tricky if you keep thinking hyperkalemic. Well, I gave up the fight once we found the genes, because once we found the mutations, we now have a better way to think about it than trying to use the clinical features to make the diagnosis. But hyperkalemic is a misnomer. This is important in terms of thinking about treatment, because you can make a hyperkalemic periodic paralysis patient hypokalemic with a treatment, and they get worse. If you make them hypokalemic, they age just like any normal person. You make them hypokalemic, you can make them worse. So occasionally we have patients where we're treating them with a diuretic, and we actually have to give them potassium as well to restore restore their low potassium. So that's the thing they do have. And those of you who have it, we put patients in the hospital, put normals in. Everybody who's normal, their potassium level stays just on a flat plateau with very, very minor fluctuations. In this disease, they're going up and down. Normally, potassium is 4, maybe a 1 or 2 tenths of a point change. In this disease, they're going from 2.5 up to 6.5 all the time, just going back and forth. So we did it for 36 hours in lots of patients and lots of normals. It's actually a diagnostic test. You can separate them from normal. So in order to make the diagnosis, you look for the mutation. We can now find the mutation. We still think that provocative testing is often helpful, because it helps you decide things about diet, exercise, and other things. They get worse with potassium loading, so I wanted to call it potassium-sensitive periodic paralysis. And there's exercise testing, which I'm not going to talk about next. In terms of the treatment, they rarely need acute treatment. We know how to treat hyperkalemia. This is often a big deal in patients with kidney disease or other things. But in this disease, they rarely where patients rarely need acute treatment. Oral glucose, not orange juice, because orange juice and bananas and other such things have lots of K in them. Beta-adrenergic inhaler can help. It's actually probably the most successful treatment. People really do need to have something. Other strategies, there are lots of ways to treat hyperkalemia. They're not usually indicated in this condition. Next. To prevent it, just remember the potassium is not that high and often not high at all in this disease. Acetazolamide, actually, Jake gave me credit for discovering this. It had been discovered earlier for hyper. We found that in hypo, and actually I've told the story here before, but I won't tell it again because many of you have heard it, but it was a patient, the way we discovered it was a patient who was misdiagnosed because of a fouled up blood specimen, misdiagnosed as hyper, given this treatment, and got better. And when they came to us, we said, no. When we finally figured out he had hypo, we said, no, this treatment, just think it's working. He said, look, doc, you may be a smart doctor, but I know this treatment is working. And that's how we found it. Put him on this medication, no more attacks. A few years later, King Engel and Marina Stalakis, who I still work with, found the dichlorphenamide was better. And that's the drug we're studying now, because unquestionably there are patients whose attacks are improved with acetazolamide, but who continue to have attacks. And we now know that in some patients, at least, dichlorphenamide is better. Thiazines are also useful. Other diuretics, there are many types of other diuretics that have been used, but I add the point that I made already. Sometimes they get hypokalemic, and there you actually need to replace the potassium occasionally. Okay, now I want to turn to just to give you sort of where I am at our group of 14 centers working on periodic paralysis are, and what we're doing in terms of periodic paralysis. And some of the major questions and challenges I just want to summarize, and then I'm going to come back and deal with each of them. Are we going to be able to get dichlorphenamide to the market? Treatment for patients, what about patients who aren't benefited by these agents? And there definitely are patients who are not benefited. Then what about patients who don't have attacks of weakness? Should they be taking treatment? Next. And what about those of you who've had careful mutation testing but have symptoms and don't have a mutation? And then is exercise good or bad for periodic paralysis? And what about should everyone who has periodic paralysis be treated even if we're not really having episodes of weakness? Okay, I'm also going to just update you on our trial and on Anderson-Tawil syndrome, and make sure you've got my perspectives on treatment. Next, okay. So here's the first question. So we are continuing to do our hyperkalemic and hypokalemic periodic paralysis study. We have now recruited over half the subjects. We changed the protocol so people do not have to go off treatment and can start on dichlorphenamide relatively soon. And in fact, if patients have severe attacks, they can go on virtually immediately once they start in the study. People have had a lot of confusion about this. Somebody said, well, I don't want to be on placebo for months. That doesn't happen. If some people think that the placebo won't help them, actually, one of the remarkable things in all of medicine is that a third of patients with any condition, cancer, pain, you name it, get a major benefit from placebo. It's amazing. It is not psychological. It's physiological response to placebo. So it is very, very important. The FDA knows this, which is why we have to do placebo-controlled trials. This is our second major trial of dichlorphenamide. The first one worked in both diseases. It was a small trial. This is a really big trial. That's why it's taking so long. The French are just coming on board. Everything finally approved. I tell you, I don't want to offend people. I've got to tell them the story. In England, if you want to bring a drug into England, you know, from the United States and do this trial, you have all this bureaucracy. It's incredible, the bureaucracy. And you got to pay them about $100,000 in various administrative fees to get your study going in England. In France, you know, you got to take them out to dinner. So I've been over there 4 or 5 times trying to, it's got to be discussed with a nice meal with wine and everything. And eventually, it takes longer. Actually, all it did was take a few really, really good meals with really, really nice wine. None of the $100,000 stuff. In Italy, all you had to do was give $30,000 and it happened in a few days. So the Italians are really fun to work with, despite their terrible difficulty in the government right at the moment. Okay, so this is our second trial. We're in discussions with the FDA. We have, as many of you know, Sun Pharmaceuticals took over our really good friends at Taro. Actually, I hadn't realized how big Sun is. Sun is one of the biggest, not just drug companies, one of the biggest companies, 10 biggest companies in all of India. And so we finally gotten them. They seem to be very, very interested now in this drug. So I'm not certain, because you can never predict what a big pharmaceutical company will do. But Jake worked with us to get orphan product designation. That is huge. That means that they will be able to write off all the costs of developing the drug and other things. So we're reasonably optimistic that this will take place. So now, what about patients who do not benefit from acetazolamide? Now, this is, we studied...
First, I'm sorry. So is there any way for patients to get drug after the trial?
No. That's why it is imperative, and I'm talking to each of you who have not been involved in the trial. We will get this trial finished soon, and be able to proceed to get this drug on the market if we can get the trial finished. And so that's why the urgency about getting the trial finished. So, but no, we are really prohibited from doing that. And we've asked, but you cannot do that. You have to have you have to have an IND for doing it, and the IND is very restrictive. Yes,
when you talk about getting the trial finished, is there a certain number of patients that you need to get to by that time, or what constitutes the study being finished?
140 patients. We have 60 in now with 20 more in screening, so we're up to 80 essentially.
So you have to get to 140 before the FDA will recognize it.
So now this is one of the things that I have been surprised at. As Jake mentioned, we found that acetazolamide benefited both diseases many, many, many years ago, and my feeling was that the majority of cases, probably, 85% is what I would have said, do get benefit from this drug. And it's probably true that about 75% get a benefit from carbonic anhydrase inhibitors. But there are about 5 or 10% who get worse with it. We think we have things to do for them, but there are patients who do get worse. And then when we looked at all of the molecularly diagnosed hypopavemic patients and looked at their response to acetazolamide, we found actually that 50% either didn't get adequate benefit or didn't get any benefit at all. So it's about 25% that aren't benefited with acetazolamide or dichlorphenamide, and another 25% who are not optimally treated, so they may need another treatment. I think probably the treatment is good for them, but it's not enough. So we've known that for years, but I've been surprised at what a large percentage of patients need a better treatment. And in fact, working with Michael Hanna and Emma Ciaffalone, we're actually in the process of submitting a grant to study a new treatment for periodic paralysis instead of dichlorphenamide or acetazolamide. And so the triamterene, Inspra, I think Dr. Lehmann talked about yesterday, this we think is a good treatment. It doesn't seem to have the side effects some of the earlier spironolactone antagonists had. It has never been studied in a big trial, and as soon as you study a drug in big trials, you begin to find what the problems are. That you find that which patients don't respond, that patients get worse, the patients have side effects that are bad. So it really needs a big trial, and we're in the process of working on this. And so for hypokalemic, potassium supplementation, particularly with these potassium-sparing agents, have to be used carefully, but we think that this is of actually major benefit in patients. Next. Now this is a really, really important point, and I'm almost certain I made it when I was here at your meeting 3 or 4 years ago. And this is something neurologists are amazingly unaware of. Neurologists who are supposed to know this sort of stuff, and even neuromuscular specialists are not adequately aware of that. And I'm making this point. I learned this when I was told this when I was a medical student. I learned it about 30 years later, what it really meant. You get motor signs before motor symptoms. Now, what does that mean? Signs versus symptoms. That means that patients who are weak are frequently unaware of their weakness. So that if you know how to test for weakness, and most physicians don't know how to test for weakness, they can find weakness, whereas the patient is not aware that they're weak. I like to tell stories about Dr. Levitt, but he says I'm strong. He's a, like me, we're both scrawny, but he thinks he's tough as nails. Okay, he is. All right, karate, and he's tough. You don't want to meet him in a dark alley. But I showed on a tape that I got. I hope you don't mind me telling you.
Yeah, no, go ahead.
That in fact he says he's strong, but he's weak. Okay, he's probably at a stage where he's about 30%. His biceps is about 30% of normal. At the time, he's sure he's normal. So,
He didn't test my rock hard abs.
not right now. but it just requires knowing how to test strength, and so that's what you get good at if you're an expert in muscle disease, because patients are often unaware. I mean, I've had patients who literally can't go up the stairs. You ask, are you weak? I say, no, I'm not weak. I said, well, you have to use your arms to climb up the stairs. Well, that's why I always go up the stairs. Or the professor, mind you, bright man who comes in, having great difficulty walking, says, look, I'm weak, but I don't have any attacks. And there are many of you who will tell me that. I'm weak, but I don't have attacks. So we put him in the hospital in the research center. In the morning, I get this semi-stat page from the nurses saying, the professor, he's quadriplegic in bed. I thought you said we had told him he wasn't going to be a problem. So I go down and see the professor. I say, Professor, you said you weren't having attacks. Now what's going on here? He says, Doc, everybody's slow getting started in the morning. And to him, that was normal. That's what happened. Get your coffee and whatever, you feel a little better. So it's like, now I'm not going to talk about the sensor, but that's equally important. Neurologists find, a patient complains bitterly of painful feet. The neurologist says your exam is normal, you're psychiatric. Not true. Okay, these are tricks. And then, so what is an attack? And we speak of attacks of periodic paralysis. I think that's, although we still do that, or episodes of periodic paralysis, I think that is really a problem term, because many, many people are not aware of the fact that they're having fluctuations in their strength. And if there's any point I can get across to you today, it's this one. I see people, just like the professor, not as dramatic, but who are having fluctuations in their strength, big league fluctuations in strength, but are not aware of it. In fact, for neurologists, it's often the case that a patient who comes to you complaining of weakness is almost never weak. Crazy, isn't it? It really is. I mean, Dr. Lewis will tell you that's really true. They may be depressed, they may have heart disease, their get up and go, got up and went, so that they are fatigued and don't feel like they have energy. But we're not talking about energy when we're talking about weakness as a muscle specialist. I'm concerned about weakness, because if I can prevent weakness, I think I can prevent you going in a wheelchair later in your life. So next. So that's my major point, and I think that every patient who has periodic paralysis is actually weak, unless they're on treatment. That's what I have yet to see a mutation on the, let's say that again. But, sorry?
No, I was
I'm
getting.
sorry, thank you. My arm is failing. Every patient who has mutation-positive periodic paralysis is weak when I see them. They say they're not weak, they say they have an attack, so I examine when they're weak. Sometimes they've lost 80% of their strength and not aware of it. They're still functioning, but they've sort of adapted. People are remarkably adaptable, and so patients who are weak don't complain of weakness typically. And they're weak, and if having attacks of weakness is bad for you, and that is, it's not proven, but I have pretty good evidence this is the case that you can put a stop to the attacks of weakness that people recognize or fail to recognize, that we may improve patients. Now, there are, and I suspect in this room, there are people who have been told they have periodic paralysis, but no mutation has been found. What is the cause of that? Is it a different mutation? Are there mutations we haven't found yet? In many instances, this is probably going to turn out to be the case. We are still finding uncommon types of new mutation in many diseases. Is there a second gene, or is it entirely different gene that's mutated? We know in Anderson-Tawil syndrome, we can only account for about 70% of the cases that have the absolutely typical picture of this disease. And so we speak now of ATS1 and ATS2, because we know there are at least 2 types of ATS, or maybe more than 2. This is a really important area of research because these patients have cardiac arrhythmias, and we think that understanding what goes on here is going to be a key to figuring out how to make patients with, in general, all the patients who have arrhythmias and from other causes. So we're working with cardiologists on this very issue. And so what defines periodic paralysis? Is it defined by the fact you have a mutation? Is it defined by the fact you have attacks? We have been studying patients for what we call P3, periodic paralysis possible, but no mutation. We're looking to see if we can figure out what they have. I have no answers, but we're working on it. Dr. Arya Pawanan with me, a lady from Thailand, a fellow, is working on this issue. So is exercise good or bad for periodic paralysis? Well, attacks tend to be precipitated by exercise, but not while you're exercising. After you exercise, you sit down and rest, and then you get weak. So you'd say, well, was the exercise bad, or was it because you should have just kept exercising? Should you be doing ultra marathons? Well, maybe not, but one thing we do know is if you are weak from periodic paralysis and exercise, it makes the weakness go away. So we think that reasonable exercise is very important and very sensible because you can build muscles in periodic paralysis or muscular dystrophy. We know that. I don't think we've ever studied any muscle disease and not found that you could actually improve their strength with exercise. But weak muscles are susceptible to injury. So if your muscles are quite weak, then you have to be very cautious with the exercise. So what I think cautious exercise is actually very good for periodic paralysis. Now, should all patients, even those without episodes, and I've given you my concern about patients who don't have episodes, I think they're having episodes that they may not be aware of. And so these are hypotheses. I think all patients, they are weak. I've never had a patient with a mutation who didn't have detectable weakness. Even young patients. Patients, I am sure, are unaware of their episodes of weakness, and I think from biopsies we've done that recurrent attacks, even attacks people aren't aware of, injure muscles, damage muscles, and that it's our job and your job to prevent the attacks. And if you're not aware you're having the attacks, then it becomes an issue of making sure you realize that you're getting cumulative damage to the muscles because you haven't prevented the attacks. They're continuing even though you're unaware you're having them. So our study, just in the last 2 minutes, we want to make sure that dichlorphenamide prevents attacks. We want to show that it's safe. We're studying it for 60-some weeks. and looking to see if it actually improves strength. We think it does. The study has had patients in it who have had side effects, so probably 10% of patients can't take the drug. We don't enter patients if they've had a bad reaction previously, but for some people it is clearly, there's very little question that it seems to be helping many of the patients in the study. These are my collaborators or centers. Lists all the people, many of them sort of a who's who in neuromuscular disease, centered all across the country and across the world. Next. So the summary of treatment, just remember if somebody's really, really weak with hypo, that's the one that seems to be so severe. Oral potassium, very, very tricky and difficult to give intravenous potassium. Why did we reported mannitol? That's to get people's attention. It isn't usually necessary. You can give little boluses of IVK. But it's almost impossible to get emergency docs to give enough potassium in intravenous fluids in a big bottle to raise the potassium. Potassium is lowered. We saw 10 of 10 patients who had hypokalemia who were treated intravenously. All 10, it went down. So it's starting at 3.4, that's probably okay, but it starts at 2.1 and it goes down, get cardiac arrhythmias, and I actually think maybe if you look at old literature, I think patients have been assassinated by physicians, meaning to correct them, giving them it's not impossible, difficult to give a glucose or saline IV and not lower the potassium. Okay. I think I've talked enough about this. Next. So, I mentioned that there's going to be ATS2, possibly 3. We are working on treating the weakness.
What's the difference between 1 and 2?
1 has a mutation in the potassium channel. 2 has no mutation in that potassium channel, but the mutation is as yet undefined. 2 groups, Lou Tachik and Michael Hanna, Tachik at UCSF, Hanna in Queens Square in London, are looking in families to find that. We're going to have the answer within a couple of years, possibly within a couple of months, as to the second gene. Yes?
When you mentioned that there were some side effects related to Zeranide, what are the types of side effects that you typically see?
The side effects we see with all carbonic anhydrase inhibitors, the big one are kidney stones. If people have had kidney stones, though, we do not stop the treatment, we treat the kidney stones. We think if people maintain a good fluid intake, they're less likely to have them, avoid getting seriously dehydrated. But we've had patients, we have actually one of the very, very first patients we treated back in the 60s, developed a staghorn calculus in their kidney. That's the whole kidney was filled with a stone. He was operated on for that. He was in a wheelchair. We said, take it out, put him back on the treatment. We took the kidney stone out, watching to make sure that if we treat any new ones that form and he's back on his treatment, he's up walking again. So the kidney stones, that's the big one. There are other side effects, pins and needles sensation. Some patients, when they're on these drugs, that carbonic and carbonated beverages don't taste quite right. And a few patients get so much tingling in their hands and feet, they don't like that. Usually people can put up with that, usually tends to get better. And a few people have gotten sort of a mental fuzziness with it. That's about 2 or 5%. Mostly that goes away too. But sometimes people say, I don't want to stay on this because of that. So we've had, I think, one patient.
But are these similar across carbonic?
Sorry? Are they the same across the world? Are they all the same? We're not sure. That's one of the things this study is going to tell us. What if you give this drug to 140 patients, what are the side effects? So we're going to find that out. But I mentioned the ones that we know. One thing we do know is that if people are allergic to sulfonamides, these drugs are sulfonamides. So we would not put people with sulfonamides on the trial. We found that was wrong, that it's a different part of the molecule, and that people who are allergic to sulfonamide antibiotics could take these drugs with no problem. We've actually done that and have 2 patients better on treatment who actually tried to, we said, let's try it. The pharmacist said, no, you can't take it. So sulfonamide allergy is not a reason not to take these.
I actually have a self-allergy, but I think
Yeah.
this is almond.
Right, it's not. So finding out, these are the big things we've got to find out about ATS, and we are working on it. I think next. So I just want to mention all the people who've worked with me from all over the world, our Channelopathy Consortium, my muscle study group. That's 50 centers with 300 investigators. The hip-hop team, which I mentioned on the previous slide, our patients, that's you, and the Periodic Paralysis Association, and Linda Feld, and others have been so helpful to us in our study. And thank you very much. Thank you all.
Yeah, I think we should.
Textbook, but close. I mean, you can look at my chin and my spine and all that. So, just tell me more about it, will you please?
Yes, Anderson-Tawil syndrome is a really important thing from the point of view of channelopathies. These are all channel diseases and channelopathies. And so one of the things that is remarkable is this ion channel mutation actually affects not just the muscle and the heart, but affects whether fingers are shaped the right way and affects facial development. And so one of the things that people early on said that patients were dysmorphic. I did not like that term because when I presented the first paper on this that defined the disease at a neurology meeting, I had pictures of the patients. I looked at them. The first 10 people came up, I looked at them. The patients looked much more normal than the people that were asking questions. So, I mean, if I say to Dr. Lewis, you look distinctive, he says, oh, that's okay. If I say to Dr. Lewis, you look dysmorphic, he's going to hit me. So I have been making a plea that we just say you can distinguish the patients, they're distinctive, but there's nothing wrong with the appearance. And so I would, in answer to your question, first, the cosmetic features, some of them, mostly they're just help us make a diagnosis, and they're fairly subtle. So it is possible to have plastic procedures for things that cause severe jaw hypoplasia, so that can be treated. Usually it's not necessary. People just look, there's a lot of variation. The psychological things, they occur. We so far do not have a common phenotype, so they seem to be distinguishable from normal. In fact, if you think about it, I think if you looked at most neurologists, you'd find that there were major behavioral differences between them and dermatologists.
The derms are happier people.
So another question, I see hands. Yeah, over here.
I have Anderson-Tawil 2, and you said that there. I have Anderson-Tawil 2, and I don't have the mutation, and you said they're close to finding another one. Now, Dr. Tawil is my doctor, and he has my blood, but it's been years since I've given it to him. And Dr. Patechek, that they did a great study on my family, came out to my city and everything, and did 144 family members.
Michigan?
Yeah.
Okay.
So I'm just wondering, is our blood still being studied, or is it on the shelves?
It's actually, you were still under study, so that but you might just write to Dr. Tawil and just ask him for an update.
Okay.
Because he's going to continue to work with us.
Okay.
Yes, a question? Sorry.
Hi, I'm probably one of the few family doctors here. I deal on a day-to-day basis with things like kidney stones, and it always concerns me giving sulfonamide-like drugs because they're competitive inhibitors of folic acid, that things like folic acid deficiency may become common in people who are using sulfonamide-type drugs. Also, if you happen to have a hypokalemic patient who has asthma, then you give them beta agonists, because if you can't breathe, nothing else matters. Have you noticed whether or not in the hypokalemic
I'm not seeing much of a problem. And one of the things that's interesting, I do think it's important to attend to potassium in patients with hyper or potassium sensitive as well as hypovolemic. But I think in most of those instances, such as with adrenergic inhaler, you can treat this with just sensible supplementation of oral potassium. What definitely does not work, you can take literally buckets of potassium prophylactically to try to prevent periodic paralysis, hypovolemic attack, and it does not work at all. I had one patient early on in my career who used to buy potassium in vat quantities, and he was taking 400 milliequivalents at a gulp at bedtime, and he was still waking every night with attacks of quadriplegia despite taking them. Now, he said that if he took it, they weren't quite as bad. When he went on to see his acetazolamide, his serum potassium fell a little bit. He had no more attacks. No more attacks, at least that we were aware of. So I thought to answer your question, I think you can manage. Now, in terms of folic acid, our requirement of folic acid is very, very small, and if one is concerned about that, you can supplement with oral folic. Oral folic, that is easy to take care of, so I would not myself consider that folic metabolism or any problem with it could be a major problem, because it's so easy to replace. There's a question back there.
Yeah, I wondered if you could speak a little bit about the role of adrenaline and stress as a trigger source, and also you mentioned sensory symptoms before sensory signs. And as the care provider, I'm always noticing my wife starts to get weak before she thinks she gets weak, but the bigger one is noticing when she starts to sense the world slightly differently than I would expect her to.
So if you talk to patients with periodic paralysis over the years, you find that there are some really interesting things that they observe. They can tell you whether they stop urinating quite as much. They have other observations that they make. And I think these are all clues that it would be good if we understand. I don't yet understand most of them. So let's see. The first part of your question?
The first part was the role of stress.
Oh, stress.
Adrenaline.
So stress certainly increases the adrenergic stimuli, which moves potassium into muscle. And so it's easy to understand why that would worsen hypokalemia. Sometimes it seems to worsen hyperkalemia, which is harder to understand. So I can't, other than that, and we have done studies looking at the movement of potassium across the forearm. That's one of the things that was interesting with acetazolamide. Potassium does not move into muscle the same way it does after you give glucose. It doesn't move into muscle the same way. So that's actually how we think it works. We don't think it has an effect on some mysterious cellular thing. We just think that by changing the ionic milieu in the body, it prevents potassium going in from muscles. We think it's the acidosis that produces.
So guys, we're going to do one more, and then we'll break, and then we'll have like an hour of just questions.
Question back there?
Yes, thank you. My main problem in life right now is constant fatigue. I've talked to other people here. They have constant fatigue as well. I wondered if you have anything to say about the causes or prevention or any kind of treatment?
So fatigue is an interesting phenomenon that physicians in general do badly with. If somebody has myasthenia gravis, that causes fatigue, and so they get weak with repeated activity, and so that is what we define as fatigue. This feeling that you just can't do things. Though if the building was on fire, you'd have no trouble running out, but you just feel fatigued and don't feel like doing things. I think there are at least one factor, can be the fact that any time a patient with periodic paralysis who is weak is trying to do things, it takes more effort and more energy. So just coping with life with modest disability is fatiguing. And so just if you're weak, you will get fatigued. over the top of that, even though you may not be increasing the weakness. So, but I would say just in general, we're not very good at explaining fatigue.
Can I add to that? Can
Sure.
I add something to that?
This is going to be the last comment, then we'll break.
Okay, I suffered from a lot of fatigue, and it really took my life away. I couldn't do the things I wanted to do. And I went to Dr. Lewis, and Dr. Lewis ordered some sleep studies and found that I had sleep apnea. And then we ordered some more sleep studies and further found that I just had hypersomnolence. Anyhow, prescribed New Vigil, and the New Vigil is a drug for people that are sleepy or have shift disorders or narcolepsy. And the drug New Vigil has completely changed my life. I used to be tired almost all the time, and it was episodic. It kind of went with my cycles. And taking potassium would sometimes give me energy and make it better, but it just didn't last. It seemed like I'd go for a week, and I was just so tired and nothing would get done. But after taking this New Vigil, my life is back. It's just a huge improvement. So someone that has a chronic feeling of just tired all the time should discuss that with their neurologist and perhaps look at that as a treatment.